at Birth Unit we have about 4,000 births per year. We cater for very low risk to quite high risk complex cases. We work as a team. The midwives and doctors work closely together so we can provide the best and most appropriate care for every patient as an individual. Every day in Birth Unit, the team of doctors, midwives and the anaesthetist meet and discuss all the patients that are presently in the unit and any expected patients. This way we're able to develop individualised care plans, discuss any complex needs and specific individualised needs. We have quite a range of analgesia options for women. We can provide non-pharmacological such as heat packs, water immersion, acupressure points, mobilisation, all these things that you can either do at home and we can help you do once you get to Birth Unit, and then we can move up to medications such as nitrous gas, morphine injection or epidurals. We also have options of perineal compresses which we can use when the baby's crowning to help relieve the pain as baby's birthing. There's sterile water injections. For some women they can have quite severe back pain and a sterile water injection into the back is very effective in relieving this.
I'm Dr. Tim Suharto. I'm an anaesthetist here at Nepean Hospital and I'm going to be talking to you today about the different options in labour. We have some pain injections such as morphine that you can have during your time in the delivery suite while you're labouring. However, we have some very strict criteria with regard to how often and how much you can have. Now I'm going to talk to you about another form of pain relief in labour, and that is probably the most well-known form, which is gas. So what I have behind me is the gas machine that we have here at Nepean. It is actually a combination of two gases. We have nitrous oxide and oxygen. The way that our machines work, it's through this tubing where we can suck in through here, the gas is delivered, and then it's expelled through another mechanism. Now, the way that our gas works is that we can actually vary the concentration of the nitrous oxide that increases the amount of pain relief that you get over a certain range. In some women, some of the side effects, unfortunately, cause a little bit of annoyance, and in some people they don't tolerate it. So these side effects include things that are annoying like tingling around the mouth, but it can make some people feel quite nauseated, and the other effect that some women feel uncomfortable with is that feeling of haziness or cloudiness. Now, the last thing I'm going to talk to you about is the epidural. This is really where we as anaesthetists get called in. And we'll talk to you about how the epidural is placed, what are the benefits and potential risks of the epidural, and what to expect after you have the epidural placed. The epidural is a targeted approach to your pain relief. It essentially intercepts the messages coming from the areas of the contraction going up to the brain, and we stop the messages at the spinal level where the epidural is being inserted. As a result, it can give you the most effective pain relief compared to other things like medications that are ingested or injected. And it has, in general, the least effects on your baby. Other benefits include an increase in the blood flow to the placenta and therefore oxygen delivery to the baby. So there are multiple benefits for both you and your baby.
Just push your lower back outward.
It's very important for the women to be positioned in a certain way. Especially sitting position helps us with opening the spaces in the back, and it makes the positioning for anaesthetist very easy, positioning the epidural.
If you feel any funny sensation, just tell me.
It's very important to communicate with the patient clearly at all times, that just to know that you're not hitting the nerves and cause any sort of nerve damage.
It is a safe approach to providing pain relief. In some women, it may not be possible to insert that epidural, and these include women that have problems with bleeding or are on medications to thin their blood. They may have problems with their back that affect their nerves, or the potential for infection either at the site or systemically. In general, 9 out of 10 epidurals work very well. In some epidurals, we need to change the medication, increase the concentration of the medication, or manipulate the epidural in order to make it work better. There are a number of other things that you need to know about. Sometimes it can decrease your blood pressure, and therefore the midwife will be there once the epidural is inserted for the first half hour, taking your blood pressure every 5 minutes. Other issues include increasing the risk of nausea, particularly if your blood pressure is low, and also shivering, which is usually a side effect of the local anesthetic. The more significant but rare risks include a headache related to your epidural, infection around the site, bleeding around the site, or trauma to one of the nerves. Having an epidural does not increase your risk of having a cesarean section, okay? But it does potentially increase the second stage of labor. That's when the baby presents, and there's potentially an increased risk of having a suction or some sort of manipulated delivery. What we do know is that for most women, one of the concerns that women have is about back pain related to epidural. And what we do know is if we look at women who have had epidurals and women who have not had epidurals, the risk of back pain is no different. But your anaesthetist will talk to you about your specific risk on the day. What I have here, which is an epidural pump. It is programmable. It is attached to the pain button. Once the epidural is inserted, it is attached to this pump, and then we as anaesthetists will program the pump so that it is able to deliver doses of epidural medication to allow you to have good pain relief. The way that we program it will be a combination where the epidural pump will be giving you epidural doses at prescribed times, and then within those times, within a certain time frame, you'll also be able to press the button and give yourself some pain relief.
I'm Kirsty, I'm a midwife and a mum of 2. With my first baby, I went in quite open-minded. I'd prepared with calm birth classes. My first baby was an induction that after I used massage, movement, nitrous, which is gas, and then from there, after 6 hours of syntocin and induction, I hadn't really progressed, so I decided that at that time it would be beneficial for me to have an epidural to help with the progress of labour. Once having in the epidural, I was able to continue in with my induction process, and approximately 9 hours later, I then had to have an instrumental delivery due to fetal distress. So having the epidural was quite beneficial, as we were able to act promptly and deliver the baby through an instrumental delivery, with me being as comfortable as possible. And then I had my second child a few years later. I was in induction again with my daughter. At a certain point in my labour, I decided that I would have an epidural because I found it beneficial first time round. So I opted for the epidural, and I found it good relief with the induction process, and then a few hours later had my beautiful baby girl.